It's next time you can put them in your doing it within the it's from
Before this cycles out. So Practice Fusion is the electronic medical record system you're going to be using over at Good Shepherd. And on Thursday, you'll get to this point when you hit log in, and you want to log in using your OKCU email address. And then when you try to log in, it'll say send the code, and it gives a phone number. With the phone number that's going to show up is our nurses, and she's going to be there. You hit send code, and it will send her a code that fast. And you put the number in here, because every time you use a different computer, it doesn't recognize it, and you have to go through this process. If you use the same computer, it recognizes it, and you can get on it at home. So you can, when you do your notes and things like that, you don't have to do them at Good Shepherd, you can do them at home. Okay. So this is what you're going to see. This is what's going to pop up here. Everybody see this okay? Okay. So over here on this side, there's a schedule, and then there's a task that you won't be dealing with. And then there's a section called charts. If you need to find somebody, you go to the charts section. I'll show you here in just a minute. But most of what you can work off is the schedule. And this is the schedule for tonight. And by the way, this is a live EMR. You're gaining access to this patient panel. HIPAA is very much alive here. So if you're using your computer, you need to log out of your computer if you bring this up. If this information goes out and you do a huge HIPAA breach, you're going to wind up probably being dismissed. So you have to treat this like the clinical data it is, okay? All right, so these are the patients. When you, on March 1st, the 6 people are going, we'll have 6 patients, and all of them will be at 9 o'clock. They'll all show up at 9. Hopefully they'll all show up. And then there you go, okay? When you see that patient, you may want to bring them back in 2 weeks for a follow-up, or a month as a follow-up. And so we'll add them onto the schedule a month from now, and then the follow-ups will be at 10:30. So all of your new patients you see at 9, the follow-ups at 10:30. So by the end of the year, you may have 1 new patient that day, but you may be seeing 2 or 3 follow-ups from your previous encounters. Okay? These are not new patients to the practice. They are all established patients, but they're here for a follow-up. So if we open up, we just open up her EMR, and this is what shows up. So the encounters you see here, this is not showing up on this screen, so I'm having to look up there. You see that's her last visit was the 23rd of January, so tonight they'll create a new SOAP note. Have they mentioned SOAP notes to you? Okay, SOAP is an acronym for Subjective, Objective, Assessment, and Plan. And we'll go over that here in just a little bit. But for these visits, there'll be a SOAP note created for that day. There'll be an encounter that you will click on, and that's the encounter you're working on for that day. Okay? You also have other useful areas of this chart. to look for is you have the list of diagnoses here. The only diagnosis she has is she's only been seen twice. That designation there, NSNC means no show, no call. She just didn't show up. So really she's only been seen to establish care, and then she was seen last month for having numbness in the face. All right, so there's a diagnosis or medications. She's apparently on no medications. Social history. And then you get down here, this is information that's been added to her chart. And this is what you're going to add to the chart too. And this is not an exercise. You're adding this to the patient's chart. This is becoming part of her medical record. All right? So, and that's kind of the way it's past medical history, major events, ongoing medical problems, family health history, and so on. Preventive care, social history. All right? So that's how these charts are laid out. And when this is the summary. This is the summary page. If you click on a particular visit, it will pull up that encounter. So instead of doing her, we're going to go and look for a patient. So I hit on charts, and I come up here, and I'm going to click on a patient here that I've seen before. His name is Eddie Lovelady. For real. There he is right there. Eddie Lovelady. Okay. He's a little bit more detailed or complex than what the last one was. So that's why I picked 3 patients here to go over, and we'll discuss things. And this is a different thing here. This is you're gonna have to change your mindset for this, for real clinic activities. You know, in the classroom, you get a lecture, you get objectives, you get objectives for the course, you get outcomes and all that kind of stuff. That doesn't mean crap when it actually gets to the classroom. Because nobody comes in with objectives tattooed on their head. These are things that you have to change the way you're thinking. You're going to have to start thinking not factually, but critically. So that's one of the purposes that we do this, is to get you to start thinking about things more globally than just a fact at a time. Okay? So if we look at, oh, there's the Good Shepherd right there. So if we look at this chart, Mr. Lovelady has been seen here 1, 2, 3, 4, 5, and then he's been seen 24 previous times. So he's kind of a frequent flyer here. Let's go over here to his diagnoses. Can everybody see that? Okay. He has quite an impressive diagnosis list here. Dyspnea, dizziness and giddiness. I don't even know what the hell that is. Dyslipidemia, so we're talking cholesterol or triglycerides. Macrocytosis, meaning his red blood cells are large. Alcohol dependence, anxiety, tobacco use, hypertension, unspecified viral hepatitis C. Wait, it goes on. Occult blood in the stool, other difficulties with micturition, meaning peeing, gout, emphysema, elevated TSH, so he has a low thyroid, nutritional deficiencies, and so on. Okay? If you look at his medications, whoa, look at all of his medications. Let's go back up to the top. So he's gone albuterol. Albuterol, you know, is a sympathomimetic used for COPD and asthma. He has COPD in there somewhere, emphysema there. Amlodipine, hydrochlorothiazide, metoprolol, those are all blood pressure medicines. That's why you're gonna have to have that Hippocrates with you, because you're gonna have to be looking up all these things to know what they are, the doses and everything, the indications. Doxepin is an anti-anxiety. Let's see, levofloxacin's an antibiotic. Why is he on an antibiotic? You gotta look at this thing and say, something's not right here. Why is this guy on an antibiotic? Well, let's go click on it. We can click on levothyroxine, no, excuse me, levofloxacin, and what does it say there? It doesn't say anything. A student volunteer put that in there. He's on 750 milligrams. It was started back in November of 2017, but probably he's not on it now. You're not typically on a maintenance dose of that. So something's not making sense here. But you know, if I came down here and hit that hide historical, excuse me, I'm sorry. If I come over here and hit historical in his problem list, he had pneumonia. That's what they treated him with around the same time, 11 of, okay, so we don't need this, he's not on this now, right? He's not on this now. We need to take it off of here. So this is one of the things I want you to do, is I want you to review their med list and correct this. So we're going to come over here, we clicked on it, we take the scroll bar, move it down, we're going to stop it today. And essentially what that does is, and we're going to record that, so it's going to take Levaquin off the med list. Now you can sit there and discontinue it and put a reason why and all that, and that's fine. But if you just hit stop today, it takes it off the list. Okay? All right, let's go down on the med list and see what else we got here. He's on spironolactone, which, okay, so spironolactone is used for several things. One is for blood pressure. The other thing is for ascites. If he has hepatitis C, cirrhosis, liver disease, he may have ascites. You know that from anatomy. Okay? Tamsulosin, trazodone, paroxetine. Oh, he's on trazodone, paroxetine, and something else for doxepin for anxiety. I bet he's not on all three. But I don't know which ones he is on, which one he's not on. That needs to be updated. Okay? All right. So that's the kind of stuff that you're going to be dealing with. Now, right here, if I go back up to the top, you see where it says flow sheets? These are the flow sheets that have been brought into his patient records. So if I hit on gout, if I open this visit right here, this was from 11 something or 17. If I open that encounter, whoop, that's me. Okay, these are the flow sheets that are brought forward. So I can look at his white blood cell count over time. I can look at his lipid profile over time, thyroid, vitals, and his blood chemistries over time. So in all of these patients, you're going to see these flow sheets. And when you get information that's relevant, it will automatically enter into the flow sheets. When you get vitals, they'll update the flow sheet for the vitals. Okay? And when the lab comes back, the nurse will update the flow sheets. All right, here's the flow sheet for diabetes, and so on. And then you're going to get down to the note. Subjective. First thing you're gonna put is you can put the chief complaint, the chief concern, and the HPI. They've been over that? Over. So that's first. One of the things that you guys haven't seen yet is the review of systems. I think the review of systems. You had a little bit of that. So they put a pertinent review of systems in this note here. Now, all the things like the surgical history, the past medical history, stuff like that, that's in the summary sheet. You don't have to put that in here. You just update the summary sheet because it's already there. These are not new patients. After that is the subjective component. So this is the physical exam component. This is what you won't know your first visit there. We will be doing the physical exam and we'll fill this part out, okay? As you learn the physical exam over the next several months, you will start doing more and more of it so that by the summer, you'll know all of it and you will enter this, okay? And then finally, after you've done your history, we've done the physical, we're gonna sit down and talk about the assessment and the plan. What is going on today? What are our diagnoses today? And what are we gonna do about them? Okay? He happened to complain that day, up here in the subjective, urinary hesitancy and continuing gout. Okay, so the two things, gout and urinary hesitancy. He's 56 years old. So we need to be concerned about his prostate. You know, that's one of the many things we have to worry about. So that's why down in the plan, one of the things we're going to do is get a PSA. I think maybe I mentioned that to you in anatomy. PSA is called prostate-specific antigen test, and we're going to measure that to see what it is, see if his prostate's enlarged. Okay? So that's our plan. He performed the digital rectal exam and ordered a PSA. No, not he did, I did. No, that's Ron Brown. You see, patient was seen by Ron Brown, PAS1. You see that up there? That's what I want you to put after every note you write. Patient was seen by you. Then we will come in and follow up, recheck everything, and then add to your note, patient was interviewed and examined by me, agree with assessment plan, me, or one of the other factors. Okay, but you sign your name. If you don't sign your name, I will track you down and make you go back in and redo it. Okay? You have to, so from now on out, you sign your name to everything. Okay? All right, so let's go look at the lab. Let's go look at the lab. The way you get to the lab is you come up to timeline, click on that, and you click on where it says encounters. And you get all sorts of different things here, documents signed. So if I was looking for an x-ray report that was signed, that's where I'd go, documents signed. I'm looking for lab results, so I'm going to go down there at the bottom and see what kind of lab results we have. Right there. And this is all the lab that's been done on Mr. Lovelady since he's been coming to us. Quite a bit. Here's his PSA right there. Let's just look at it real quick. It's 0.2. As long as it's less than 4, he's in good shape. Okay, so it's not his prostate that we're worried about in terms of prostate cancer or prostate enlargement at this point. Okay? Let's look at some other labs. How about this one right here? Quantiferon gold. Quantiferon gold is a test. Have you had that? Did they do that to you yet? Okay, so when you test for TB, and you'll have to do that every year now for the rest of your life, if you're involved in clinical activities, they used to do a little thing called a PPD. They squirt a little stuff on there, 48 hours, you come in, the nurse checks it, and you're negative, right? A more sensitive test now is called QuantiFERON Gold. And what this is a blood draw, and then they take your blood, and then they add antigen from tuberculosis bugs in there, and then the white blood cells that are in there react to the antigen and secrete interferon. And they measure the interferon. So that's the test. It's an interferon assay, really. It's a direct measure of your cell's exposure and reaction to TB. It's a more sensitive test for active TB. And his is positive. Uh-oh. Now there are 3 different tests that validate the QuantiFERON Gold, and they're listed below there. These 3 tests right here, 1, 2, 3. And this explains those 3 tests. If you read this stuff down here at the bottom, and you look at these values here, it is saying, yes, he has TB. He has TB. Well, if he has TB, he doesn't have to be seen at Good Shepherd. His happy butt needs to be at the state's TB control center. Okay? So that's where we're sitting. Okay, so we got him back. We got him back from the TB control center with, let's go to document signed, TB clearance. This came back from the TB control center, essentially saying that he's okay to re-enter society. They did their stuff, had a negative chest x-ray, all these other things, so he's good to go. Repeat the QuantiFERON Gold, which you should do anyway, to make sure it stays positive or negative. All right? So we're good. We're following their recommendations. That's fine. Okay, so while we have Mr. Lovelady up, though, let's go back and look at some other labs. All right, this is where you always find the lab results. We're going to scroll down and look at some lab. If he had gout, then what should be elevated if he had gout? Uric acid. So let's look down here for uric acid. This is really annoying that I don't have this on my screen. There's one right there, uric acid. His uric acid is 9.7. So it's a little elevated, right? Okay, that supports his diagnosis of gout. That's fine. That's fine. Let's look up one above that. Look at all this lab right here. Let's look at that. That looks like it ought to be pretty interesting. Find out everything about this guy. Look at his cholesterol. His total cholesterol is 161. What's a normal total cholesterol? What should it be? What?
125 to
200.
200.
Less than 200. Less than 200. Less than 200. You sound like you have experience in that.
It tells you the reference range.
Oh, right there. Okay.
I said it too.
All right. So we want it less than 200. HDL cholesterol, that's your good cholesterol, right? You'd like to see that above 40. His is not. So if it's above 40, it's a negative predictor of coronary artery disease. But it's less than 40, so it's not really a negative. It's, I guess you could call it a positive. Triglycerides we don't even care about unless they're over 1,000. LDL cholesterol is calculated. I don't have an estimate right there. We'll get it later on. Keep on scrolling down. Hepatitis. Now we're getting to the hepatitis panel. Non-reactive for A, non-reactive for B. non-reactive for B again, reactive for C, okay? Pretty healthily reactive to C, as I might add. So does he have active hepatitis C, or is it latent? Well, we'll find out later on. His HIV is non-reactive, that's good, that's good. What is that? His LDL, there we go. I don't know why his LDL showed up way down here, but it's 79. You want the LDL, if you have comorbidities, you want the LDL less than 100. So we're in good shape there. He is. All right, magnesium, I don't know exactly why they got that, but they did. His glucose, slightly elevated, but the normal high is 99. So one of the things about lab is that you have to look at what you're measuring and how far out it is. The normal distribution for lab is on a bell-shaped curve. That most people on a value are going to be in the middle, plus or minus 2 standard deviations. But that's still going to leave you these people out here of high and low that are outside the normal range, but they don't have disease. I would consider that where he's landing here. 109, he may have had a donut before he went in. You don't know. It's not diabetes. It's not the definition of diabetes that you're going to get later on. It's slightly elevated. Nothing to worry about. Okay? All right, so as we scroll down through here, his creatinine, which is a measure, and BUN, which are measures of renal function, are normal. That's good. That's good. He doesn't have any renal disease. Now we get to sodium and chloride, which travel together. They're both low here. I don't really know why they're low, but they are low. I'm not worried about that right now. Let's keep on going down. Here are 3 liver enzyme studies. These are pretty high. Not way high, but he has hepatitis C. Okay? So we need to watch these. You can go back in that flow sheet and see that they've been high consistently. All right? These are intracellular enzymes. So if the amount increases in the blood, that means that you have more cellular damage. You're releasing more of this enzyme into the circulation. So over time, if he keeps losing hepatocytes, he's going to wind up with liver failure, right? Okay. Here's his white blood, his cell count. Notice that his MCV, this is called mean corpuscular volume, is high. Remember the macrocytosis that he had? Macro is high. His volume is big. That's what you usually see in alcoholics. Big red blood cells. A macrocytic anemia, although he doesn't have anemia because his hemoglobin is normal. But he's headed there. All right. Platelet count's not as low, not alarmingly low. I don't really get upset until it starts dropping below 100,000. He's headed there. Okay. His INR and his PT. PT, there are 2 measures of clotting. PT and PTT. PT looks at one, you have an intrinsic pathway of clotting and an extrinsic pathway. You're going to get a lecture on this later on. PT measures one, PTT measures the other. PT measures clotting factors that are made in the liver. They're made in the liver. So people with significant liver disease like cirrhosis, hepatitis, they're going to have an elevated PT, which he does. Not much, but it's still elevated. And an INR, I'll go over that later when we do a clotting study. INR there's a calculation from PT that gets you the INR. Okay? They're both elevated, bottom line, is meaning There's both liver involvement in his clotting cascade. Remember I was telling you about the people with esophageal varices bleeding out? There you go, right there. Okay. What else have we got? Somebody's looking at him. When this lab was drawn, I don't know when this lab was drawn, with visit, but they're looking for tumor markers. There are different tumor markers for the liver, like hepatocellular carcinoma. He's got hepatitis C. What's the problem with hepatitis C? An increased prevalence of hepatocellular carcinoma. So they're looking at tumor markers, alpha-fetoprotein, carcinogenic embryonic antigen, CEA, and CA125. These are different proteins that are expressed by tumors. Okay? They're all negative. That's good. All right, here's his hepatitis C viral load, essentially. Normally, you want less than 15 copies per milliliter. He has, what, almost 600,000? So he has active hepatitis C.
Million.
I'm sorry? What?
6 million.
Million?
Yeah.
That's even worse. Yeah. So you don't want a needle stick from this guy, okay? All right. His hemoglobin A1C, which is a measure of your blood sugar over the past 3 months, is normal. So that blood sugar of 109, not a big deal. Okay? You'd like to see your A1C of less than 5.7, that's normal, which his is. All right. So that's Mr. Lovelady. One of you guys are going to get him. He's a rather complicated patient. One of the things that's complicated about him that the student couldn't seem to understand last year is he's an alcoholic. He's a raging alcoholic with hepatitis C. You want to kill your liver, combine those two. He doesn't want to change anything in terms of his alcoholism, and they're not going to put him on the treatment for hepatitis C unless he stops drinking. So he's essentially going to kill himself. And, well, there you go. Okay? There's nothing you can do about it. All right? That's Mr. Lovelady. Any questions about Mr. Lovelady? Any questions? The purpose of this afternoon is I'm just showing you around the EMR. I mean, I don't expect you to know this lab. I don't expect you to know these drugs. You're going to get that this year. But I need you to be able to navigate in the EMR real quick.
You mentioned before on this patient that he obviously tested positive for hepatitis C, but it was referred to CDC.
It was referred
It
to.
was, I'm maybe I'm getting it mixed up, but after he tested positive for hepatitis C, how do you know if it is, like, is it a chronic thing? Is it an acute thing? Does it diminish over time?
So if you wound up hepatitis C positive, you want to know, is it active?
That's,
Because if you test everybody my age, what is it, like 20% of people my age are hep C
Pretty
positive?
high, yeah, that's
Yeah.
probably good.
You know, we just, back in the 60s, we were just, injecting drugs every day and having sex with everybody. And so 20% of us are hep C positive and walking around don't even know it. So is it active or is it just there, late? So a hep C viral load was done on him, and sure enough, he blew it up. So he has active hepatitis C.
To the clinic, did we wear business attire in our white coats? Like slacks?
Yes. Yes. You don't have to wear, guys don't need to wear a tie, but a decent shirt. Like a button shirt, not a polo shirt or a t-shirt. No jeans. Closed-toed shoes, no sandals of any type. And so I'll explain more of that when we get over there on Thursday, when I show you around.
So this patient you said was treated for depression also. Could you attribute his problems with depression with the alcoholism and really not caring if he betters his life, or is it just pure stubbornness?
You know, I don't know the answer to that. I haven't dealt with him on depression. It was more or less stabilizing what he was in for that day. He's on, Dr. Latassi, he's on doxepin. Let me get to his med list here. Can't find it. There's the pointer. You guys see the pointer? Oh, there he is. I don't know where he went. He's on doxepin, he's on
Paroxetine.
Prozac, and he's on trazodone. Now, I don't know if he's taking all of these, but the med list has not been updated. And the reason Dr. Latassi's here is that when we go over there starting in March, Dr. Latassi or Dr. Britton, or both of them, will be there. This is an interprofessional thing. And Dr. Jones, the physical therapist, will be there to help out too and give guidance on drug therapy, physical therapy, and it's a team-based approach here. He's also, regarding his blood pressure, we've got spironolactone, metoprolol there. We've got HCTZ, we've got amlodipine, so he's on quite a bit. If we go to his, if we go up to his, what's his blood pressure been running? His blood pressures are pretty okay. You know, one of the things, as I mentioned earlier, we want you guys doing is making sure you confirm with the patient what they're taking, how they're taking it, and the dose they're taking. Okay? All right, so let's move on to another patient here. We're going to go back to charts. We're going to go up here, and we're going to type in another name. Mr. Tipsworth. Ronnie Tipsworth. Okay, let's check his diagnoses here. He's a 62-year-old male. He has hypertension, iron deficiency anemia. He has dyspnea on exertion, reactive hypoglycemia, screening, let's see, chronic kidney disease, stage 4. How many stages are there in chronic
Well,
kidney
there's a
disease?
5.
Stage 4, 5. Stenosis of the right carotid artery. He's got diabetes, anemia of chronic disease, which anemia of chronic disease goes hand in hand with renal disease because the kidneys produce a hormone that causes your marrow to turn out red blood cells. If you have dead kidneys, you're not going to make red blood cells. They go hand in hand. As we're scrolling down through his diseases, start to pick up his medications here. Let's see, amlodipine, aspirin, carvedilol, clonidine, Plavix, which is a platelet aggregator inhibitor, ferrous gluconate, furosemide, Lasix, which is making pee. If he's in renal failure, that would help. Hydralazine is another, it's alpha blocker.
So it's a direct vasodilator.
Vasodilator. And then he's got also hyperlipidemia, delay when starting to pass urine. Remember I talked to you about that? Enlarged prostate, okay, type 2 diabetes. Wow. So he's got a lot of stuff going on for a guy my age. What other medicines are he taking? Oh, it goes on and on. Well, let's see here. He's on Vistaril, I guess he itches somewhere. He's on insulin, okay, he's on insulin.
Or anxiety, sometimes they'll use that.
Yeah,
as a-
yeah. I think it did say he had an itchiness somewhere. Vistaril is like a antihistamine.
Yeah, it'd go along with his renal disease.
Yeah, it's really good for that. Insulin, okay, ranitidine for his stomach, I suppose. Simvastatin for his lipids, right?
Yeah.
Sodium bicarbonate. Now, why is he on antacid? Is he taking an antacid? Wow, a lot of stuff going on with this guy. What happens with people in renal failure?
Go on dialysis?
Metabolic acidosis. Is that why he's taking sodium bicarbonate? Or is he really taking it for his GERD? So he's got a few things, okay, oh, the med list goes on and on. He's on terazosin. Terazosin is, that's blood pressure, right?
It's an alcohol, yeah, it's a
Alcohol.
peripheral.
Oh, it could be for his pee.
Right.
Yeah, alcohol to making pee. And he's on triamcinolone cream for something he's got, or maybe the itch. The itch, he's got the itch going on. Okay. I think he had itch, urticaria. Wasn't that on his disease list? If it's not, it should be. Okay. All right, what do you want to see with this guy? What do you want to see with this guy? Let's go over and look at his lab. Let's just take a look at it. Encounters, when we go to encounters, go down here to lab results. What do we got here? Let's look at this one first. You just click on the box and it shows up the whole thing, and you just scroll down. Cholesterol looks pretty good. LDL is a little elevated for his chronic diseases. His iron. Right now it's looking okay. Right now it's looking okay. His glucose is 201. Remember, it needed to be 99 or less. So anytime your blood sugar is over 200, I think fasting or any time, it's diabetes. Is that the current?
If you, you can do a random if they have also symptoms that are consistent with hypoglycemia.
Over 200 though is considered.
If they have symptoms, yeah,
All right.
if there's symptoms.
Let's look at his creatinine here. Creatinine is what? 5.6 to, or you see where it says 1.25? So I'm gonna tell you, every doubling of creatinine cuts your kidney function in half. So if you take 1 for creatinine as a starting point, he went from 1 to 2, so now he's down to 50%. He went from 2 to 4, so now his GFR is 25%, and now he's over 5, he's close to 6, so now it's less than that. So his renal function is pretty piss poor. If you look down here at the bottom, they estimate the GFR. He is, I think he's a Caucasian, does it look Caucasian in the picture? Okay, so there is a difference between blacks and non-blacks.
He's African
in terms of
American.
GFR. He's African American, okay, so his calculated GFR is 12. 12, so his kidney function is essentially 1/10 normally what it should be. So this guy's headed for dialysis probably. He's pretty close to it if he's not there already. Okay. What else is going on? Carbon dioxide we don't need to worry about. Calcium is 8.5, that's a little low. People with renal failure have a low calcium. They just normally do. If we go back up to here, the timeline, and look at this thing right here, PTH. If you have what elevates serum calcium? There are two hormones that control calcium. Parathyroid hormone and calcitonin. I told you, back in anatomy, I told you, you never forget anything she or I say, ever.
Yeah, that'd be good.
Yeah, you never get anything. Parathyroid, pair up. Parathyroids increase serum calcium. So if serum calcium is low, what do you think the PTH is gonna be? Say it again.
Low.
What?
High.
What?
High.
Well, I
You're
thought,
eventually gonna get it. So his parathyroid hormone is screaming, trying to get his serum calcium up. And it's only brought it up to 8 point something, still low. Right now, there are guidelines for when you refer somebody to a nephrologist, and this, along with creatinine, this guy needs to be followed by a nephrologist, because this guy's in pretty bad shape here.
Is yours good now?
Get an albumin? Yeah, let's go back to the other, this one right here. His albumin should be on his blood chemistries. There's his glucose.
There it is.
There's an albumin right there, which is normal. So one of the things you gotta worry about in liver disease or alcoholism is their drinking, their calories. So the albumin is gonna be low. You're asking it for
Calcium.
calcium. Calcium and albumin, when you look at a calcium value, half of the value is bound to albumin. Half of it is not. So if the albumin is low, then the calcium value you see up there needs to be increased. Because let me explain it another way. For every 1 gram decrease in albumin, you have to increase the calcium value you get by 0.8. For every 1 gram decrease in albumin, you increase calcium by 0.8.
Because
So,
the free fraction goes up, we've been over that.
okay, because the free fraction goes up, and it's the free fraction that's metabolic, not only metabolically active, it's the free fraction that's active at the cellular level. So you're gonna wind up with all types of cardiac arrhythmias and things like that if you have an increase in the free fraction of calcium, which is dependent upon the albumin level. Okay? What else do we have going on here? White blood cell count, oh, look here. His hemoglobin is 10. Normally, in a guy, it should be at least 13. And so that gets back to the erythropoietinogen, which is secreted by the kidneys, that produces red blood cells. If his kidneys are dead, he's going to be anemic. It goes hand in hand. Okay? These relationships that we're going to be talking to you like this about, these are things you need to put to memory. Because when you see these on your patient, you need to be able to make this correlation. I've already told you about metabolic acidosis and renal disease. I talked to you about albumin, calcium. We've talked about, what else? Hemoglobin and renal disease. These things you need to remember. The other thing about renal disease is potassium. People with renal disease have an issue with potassium. What is his potassium? I think it's normal, 4.2. That's something, I think, on the next patient. You gotta watch out for potassium in renal disease, and how you treat things like their hypertension, because hypertensive drugs have an effect, a lot of hypertensive drugs have an effect on serum potassium.
But you have to look at acid-base status when you evaluate potassium. So his carbon dioxide, CO2 content is low, so that makes that potassium a little bit worrisome, because hydrogen ions will move in intracellularly, potassium moves out, so it probably represent a slight decrease in total body potassium.
Yeah. Okay? All right. Anything else we want to talk about regarding Mr. Textor? Okay, let's go one more, we look at one more.
Do you tell them that most of the people they see will have this complexity level?
Yeah, we're not gonna give you simple patients.
Well, I don't think there are any.
Well, you're probably right about that.
I haven't seen it.
Shucks, oh man.
Emilio Rivas. Emilio Rivas is a 52-year-old person. Well, they have diabetes, they have hyperlipidemia, they have congestive heart failure. And by the way, I got these patients off of the list of patients that our students saw last year, so. They have renal impairment, hyperkalemia, think renal failure, hyperkalemia. Okay. Hypertension, peripheral nerve disease, that's due to the diabetes. Stage 3 kidney disease, edema, anemia of chronic kidney disease. What are they on? Look at what they're on. Amlodipine, Norvasc, 5 milligrams. That's the same thing I'm taking. That's good. We're good. Aspirin, that's the same thing I'm taking. 81 milligram aspirin, that's good. That's all good. Calcitriol, what? What is somebody Google up calcitriol. Anybody know what it is?
Isn't it
Cassie knows.
What is calcitriol? Where do you get calcitriol?
It's a vitamin for low calcium.
It's a vitamin for low calcium.
And psoriasis.
Okay, so we need to do a little bit more research on calcitriol and calcium. What regulates calcium? And so this is what, when we come across things like this and we tell you things like this, we want you to go home and look it up. Calcitriol, calcidiol, 1-hydroxy vitamin D, renal absorption of calcium, gut absorption of calcium, inhibition of urinary excretion of calcium, parathyroid hormone, calcitonin, all of these things regulate calcium level. His calcium level is so whacked, they've got him on a hormone to try to get his calcium level up. It does that by either increasing calcium absorption from the gut, I don't think it does, or increasing calcium reabsorption from the kidneys. If you look it up, I think that's how that works. Okay? That's an interesting thing to be on. Carvedilol, clonidine, those are blood pressure. Erythropoietin or epoetin alpha. What is epigen? What is that? What is that?
Something to do with making red blood cells?
What did I just say came from the kidneys? So they're trying to stimulate his marrow to make RBCs. His anemia is so bad. Okay? This guy's how old? 52 years old. What else we got going on here? He's on ferrous sulfate, he's on iron. Furosemide Lasix is a loop diuretic, it makes you pee. He's on 80 milligrams, which is a pretty whopping dose. Why are they trying to make him pee? They're trying to make his kidneys keep working, and they're trying to get rid of any edema he may have. But when you use Lasix, the problem is you pee out potassium. But in people with chronic renal failure, do they have too much or too little potassium?
Too much.
Well, we're gonna find that out. Okay. He's on insulin, oh, he's on gabapentin. Gabapentin is, a what? Neuropathy. It can be used for other things, but neuropathy is a good one. He's on insulin, he's on ranitidine, he's on a statin. He's on Januvia. What's Januvia? Is what? Diabetic medication? What's the difference between that and insulin and Well, those are the two that he's got going on right now, right?
Isn't Januvia long?
Huh?
Isn't Januvia long acting?
Long-acting have you done diabetes at all? Okay. You look it up, okay? And he's on sodium bicarb as well. Okay. You wanna see what his labs look like? I bet
Yes.
they're not good. Oh, let me go back one other thing here. Go back to the summary. Under his past medical history here, these are his current diagnoses. If you see one of these that doesn't belong there, doesn't need to be in there anymore, take it off. But under his past medical history here, major events, he's got right here hospitalization for hyperosmolar syndrome and hypertensive. What is hyperosmolar syndrome? It's what?
Probably something with like osmosis or fluid going in and out of the veins. I have no idea.
Why would you?
That was a guess.
That was a good, not a bad guess at all, not a bad guess. What is, so he's a type 2 diabetic, but he's on insulin, so he's an insulin requiring type 2 diabetic. Type 1 diabetics get DKA. Type 2 diabetics, if their blood sugars get up into the hundreds and hundreds and hundreds, they can wind up in a hyperosmolar state, and it can produce symptoms all the way up to death. Okay, so that's, his hyperosmolar problem was enough to get him admitted somewhere. Okay, so, all right, so we're gonna look at his last two labs here. Parathyroid hormone on him, like the last person, is high. Right, his calcium, he's peeing calcium, his PTH is high. His calcium level here, though, is normal, so he's keeping up with it right now. Let's go back to this one right here. All right. This is urine creatinine. It's okay. His urine creatinine is okay. His microalbumin, meaning in the urine, means he's peeing protein in the urine. Normally you'd like to see that below, that and the next one, below 30. Below 30, he's peeing out over 1 gram of protein. That's a lot of protein. No, that's micrograms. He's peeing out over 1 milligram of protein in this sample. That's a lot of protein. That's why people in renal failure, they have a big problem with fluid balance. The oncotic pressure of the blood, the serum, isn't right. So they wind up ballooning up, getting really puffy. Along with that can have all sorts of effusions and lots of problems like that, okay? We're gonna I'll give you a lecture later on hydrostatic forces in blood and oncotic pressures in blood and how these affect the normal fluid balance in an individual. All right, so if we look down here, well, the glucose is not so bad. His creatinine is
Not very good.
9. As a general rule, so his GFR is in the single digits now. This guy's, he's not a stage 3. I think it said stage 3 earlier on.
Yeah, and hemophilia.
No, this guy's gotta be on dialysis. Generally, if the creatinine is above 7, you're on dialysis. And he's way above 7. So he's not good. Potassium, look at the potassium here. 5.7 is elevated. Yep, it's elevated. Calcium's 9.3, and I don't know where his don't think I have an